Woolfield.
I'm Mel Acreman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Today, we're going to introduce you to a really important issue, endometrial cancer. We'll cover incidence, risk factors, clinical presentation, and classification.
Endometrial cancer is the most common gynecological malignancy in Australia and New Zealand. Every year, more than 3,300 Australians and 700 New Zealanders are diagnosed with uterine cancer. It's estimated that a woman has a 1 in 44 chance or a 2.3% risk of being diagnosed with uterine cancer by the age of 85. In Australia, this reflects a doubling of case numbers over the last 20 years, and in New Zealand, the numbers have tripled. Even more alarming is that global estimates predict another 50% increase in case rates by 2040. Not only is the incidence of endometrial cancer on the rise, but the number of women dying annually of the cancer is too. Mortality data captured by the Australian Bureau of Statistics showed that endometrial cancer was the only gynecological cancer that showed mortality rates rising.
Oh wow, that is terrifying. What is going on? Do we know why we're seeing such a spike in endometrial cancer rates?
When we look at the breakdown of the data, it seems that the rise in endometrial cancer is mainly due to an increase in cancer in patients aged 60 to 79. In women under 40, endometrial cancer remains a rare occurrence, occurring in about 2 per 100,000 women. Despite this, there is some alarming data that shows a rising incidence of endometrial cancer in premenopausal women that coincides with an increase in obesity. There seems to be a few reasons why endometrial cancer rates are rising, and these are mostly due to an increase in the prevalence of risk factors. Firstly, we have an aging population. Since the baby boom, we've now got a large proportion of women entering their 60s. Since the risk of developing endometrial cancer increases with age, it makes sense that with an aging population comes a higher rate of age-related cancers. But probably the most significant reason why we're seeing higher rates of endometrial cancer is obesity. It's no secret that the average BMI of the population is increasing, and as we mentioned in our previous episode on endometrial hyperplasia, obesity is a massive risk factor for the development of endometrial cancer. Increased adipose tissue increases peripheral conversion of androgens to estrogens, thus increasing the presence of endogenous estrogen and increasing the risk of endometrial cancer. Obesity is also associated with insulin resistance. Insulin resistance can lead to increased insulin production by the pancreas. Higher insulin levels can stimulate ovarian androgen production and inhibit hepatic sex hormone binding globulin production. Decreased sex hormone binding globulin levels can result in increased bioavailability of free estradiol, further contributing to higher estrogen levels. Obesity is such a big contributor to endometrial cancer. And in fact, 83% of women with endometrial cancer are obese and 52% are morbidly obese.
So let's take a moment to recap the risk factors for endometrial cancer. Obviously, we've got age and obesity. What are the other risk factors?
Remember, the majority of established risk factors stem from the effects of unopposed estrogen on the endometrium, which results in proliferation of endometrial cells, which can lead to hyperplasia and malignancy. These include early menarche, late menopause and nulliparity, PCOS, diabetes, estrogen-only HRT, insufficient exercise, estrogen-secreting tumours like granulosa cell tumours of the ovary, tamoxifen use, and then there are the genetic causes like a family history of Lynch syndrome, Cowden syndrome, or endometrial cancer.
I've also heard that certain chemicals found in hair straighteners might also increase the rates of endometrial cancer. Is that true?
Yeah, so this is a relatively recent finding that was published in a paper in 2022 by Chang et al. Previous studies had found that hair product use was associated with a higher risk of hormone-sensitive cancers like breast and ovarian cancer. And so Chang decided to investigate the relationship of hair products with uterine cancer. They examined associations between hair product use and uterine cancer among 34,000 women. Women self-reported their use of hair products in the previous 12 months, including hair dyes, straighteners, relaxers or pressing products, as well as perms or body waves. They found that use of straightening products was associated with higher uterine cancer rates, but that other products were not. Now, just to be clear, this study was looking at chemical straighteners. So don't worry, ladies, you can still tame those unruly locks with your GHD.
Now, it's not all doom and gloom. There are some factors that are actually protective against endometrial cancer. In fact, 34% of endometrial cancer cases are related to lifestyle and other external risk factors and that are therefore considered preventable. Obviously, there's diet and exercise. Clearly, weight loss and reducing obesity goes a long way in reducing endometrial cancer. But there's also favourable changes in the immune system and endogenous sexual and metabolic hormone levels and growth factors. In fact, for each hour of exercise you do per week, you reduce your risk of endometrial cancer by 5%. Coffee drinkers can also rejoice. The more coffee you drink, the lower your risk of endometrial cancer. For those who drink tea, green tea is more protective than black tea.
Hormonal contraception is also incredibly protective against endometrial cancer, reducing the risk by 30 to 40%. That risk reduction actually continues for several years after you stop your contraception too. In fact, progestins are so protective that they can even be used to treat endometrial hyperplasia and early-stage endometrial cancer. Interestingly, the copper IUD is also protective. Pregnancy is also protective, possibly due to the role of progesterone activity throughout pregnancy. This protective benefit extends to those patients who got pregnant but had a termination, and also for those women who gave birth at an older age. For example, women who last gave birth at age 35 to 39 have a 32% less risk of endometrial cancer than women who last gave birth under 25. Women who breastfeed for at least 3 months also have about an 11% reduction in endometrial cancer compared with women who did not breastfeed. We don't really know why, but it's thought that low estrogen levels during breastfeeding may have a protective role.
And not that we want to advertise this, but cigarette smoking is also associated with a reduced risk of developing endometrial cancer in postmenopausal but not premenopausal women. It's thought that smoking stimulates hepatic metabolism of estrogens, leading to a reduced incidence of endometrial abnormalities. Now, that does not mean that you should take up smoking to reduce the risk of endometrial cancer. You are far more likely to develop respiratory complications, infections, or other cancers from smoking. And so the major health risks of smoking definitely outweigh the benefit of a reduction in endometrial cancer. Smoking is terrible for almost all aspects of your health, so never smoking or quitting is actually the best thing you could do for yourself.
But an important point when it comes to different MCQ exams. So what else can we do to prevent endometrial cancer? We've just discussed the benefits of achieving a normal BMI, engaging in regular physical activity, breastfeeding, and using hormonal contraceptives. Are there any other strategies we can take if we want to reduce our risk of endometrial cancer?
Although diet and exercise are obviously helpful, for some patients with obesity, losing weight is an incredibly difficult task. For these patients, bariatric surgery may be a reasonable option. Bariatric surgery has been associated with a 50 to 80% reduction in the occurrence of endometrial cancer. For those who can't lose weight, progestin-dominant contraceptives, like the Mirena, may also provide sufficient protection. Ozempic may also be an option, and although studies have not specifically shown a reduction in uterine cancer, they haven't shown an increase. Patients with anovulation, like those with PCOS or in the perimenopause, will also benefit from progesterone-containing contraceptives like the Mirena or even the combined oral contraceptive pill. For those on tamoxifen, the Mirena has been proposed for prevention of endometrial hyperplasia and cancer. However, the safety of the Mirena in patients with progesterone-positive breast cancer has not been established, and so this decision must be made in conjunction with the patient's oncologist.
There is also the option of hysterectomy for those patients at high risk of endometrial cancer, and by that we are mainly referring to patients with Lynch or Cowden syndrome. Women with Lynch syndrome have a 20 to 60% lifetime risk of endometrial cancer, and so for these women, we typically recommend a prophylactic total hysterectomy and bilateral salpingo oophorectomy after childbearing at around age 35 to 45.
If endometrial cancer is such a big deal, why don't we have a screening program for it?
Endometrial cancer has quite a few characteristics that inform the recommendation against routine screening. Firstly, 75 to 90% of patients with endometrial cancer will present with abnormal bleeding. The good thing about endometrial cancer is that it usually lets you know that it's there. In the vast majority of patients, symptoms occur early when the disease is still confined to the uterus and can be easily treated. The second argument against routine screening is that we don't really have a good enough test to detect it. Pelvic ultrasound to detect a thickened endometrium is sensitive in postmenopausal patients with abnormal bleeding. However, in asymptomatic patients, the sensitivity is much lower, and the false positive rate is high, meaning we are likely to do far more endometrial biopsies than is necessary. We can't really be doing endometrial biopsies on everybody either. It's invasive and uncomfortable, and again, unnecessary for the majority of the population. For patients who are at high risk of endometrial cancer, for example, those with Lynch syndrome, we actually do perform screening. For these patients, we recommend annual Papel and transvaginal ultrasound from the age of 30 to 35 and at least 10 years prior to the earliest Lynch-associated cancer diagnosis in the family.
So, how do we detect endometrial cancer?
Well, as we said before, the most common presenting symptom for endometrial cancer is abnormal uterine bleeding. The amount of bleeding doesn't correlate well with the risk of endometrial cancer, but age and risk factors do. Most cases of endometrial cancer occur in patients over 55 years of age who present with postmenopausal bleeding. But endometrial cancer can also occur in younger women. Women over 45 tend to present with intermenstrual bleeding, frequent, heavy, or prolonged bleeding. They might also have prolonged periods of amenorrhea due to anovulation. In women under 45, abnormal bleeding tends to be persistent and occurs in the setting of unopposed estrogen exposure, like obesity or chronic anovulation. It can also occur in failed medical management of bleeding or in patients at a high risk of endometrial cancer, for example, those with Lynch syndrome. A small percentage of patients will actually present with abnormal findings on their routine cervical screening test. These findings might include endometrial cells, atypical glandular cells, or adenocarcinoma. In other cases, endometrial cancer may be detected due to a biopsy for an incidentally detected thickened endometrium or as an incidental finding after hysterectomy. For this reason, all patients with abnormal uterine bleeding undergoing a hysterectomy should have endometrial sampling with the results available before the hysterectomy. Almost 1 in 100 patients having a hysterectomy for benign indications will have an occult uterine malignancy. In all patients, endometrial cancer is typically diagnosed on histopathology, either an endometrial biopsy or through a hysterectomy specimen.
Okay, so let's talk a little bit more about the different types of endometrial cancer. You might have noticed we've used the term uterine cancer and also endometrial cancer. Today, we'll be focusing mainly on endometrial cancer, which accounts for about 95% of uterine cancers. But there are other types of uterine cancer that can arise from the different tissues within the uterus. These include sarcomas, which arise from the stromal tissue, leiomyosarcomas, which arise from the smooth muscle, and mesenchymal tumours.
Traditionally, endometrial cancer was divided into type 1 and type 2. Type 1 endometrial cancers were the more common, lower risk, and estrogen-driven cancers that typically arose in thickened endometrium, were usually low grade, diagnosed at an early stage, and had a good prognosis. Type 2 endometrial cancers were much less common, higher risk, and not hormonally driven. These cancers arise in atrophic endometrium, are often high-grade or non-endometrial types like serous or clear cell, and are typically diagnosed at later stages with a poorer prognosis. Type 2 cancers are typically driven by p53 mutation rather than exposure to excessive estrogen. Now, this classification system is not really helpful in terms of clinical outcomes, and so there has been a shift away from this in favour of other classification systems that include histological diagnosis and molecular subgroups.
In 2020, the WHO published a classification system of tumours of the uterine corpus. The system divided endometrial carcinomas into their histological subtypes: endometrioid carcinoma, serous carcinoma, clear cell, and carcinosarcoma. It also includes undifferentiated, dedifferentiated, mixed carcinomas, and other endometrial carcinomas. These different histopathological types have different molecular features, microscopic appearance, precursor lesions, and natural history, and are essential to accurate staging. Endometrioid carcinoma is the most common histology, accounting for 75 to 80% of cases. Endometrioid carcinomas are typically comprised of tall columnar cells that are graded based on architectural pattern, which includes the percentage of solid component. Grade 1 being less than 5% solid component, grade 2 being 6 to 50% solid component, and grade 3 being greater than 50% solid component. Marked nuclear atypia can also raise the grade by 1. Most endometrioid carcinomas are low grade, diagnosed at an early stage and have a good prognosis. About 5% have P53 mutation subtype, which behave more aggressively and have a poorer prognosis.
Serous endometrial carcinoma is the second most common type of endometrial cancer, but only accounts for about 10% of cases. Serous carcinomas form papillary structures and have marked nuclear atypia. Most serous carcinomas are of the P53 molecular subtype. Human epidermal growth factor receptor 2, or HER2, is abnormal in a minority of these cancers and can sometimes be targeted therapeutically. Serous carcinomas are typically associated with invasion. However, if it is confined to the endometrium or a polyp, then the disease tends to have a good prognosis.
Clear cell carcinoma is an uncommon subtype, accounting for less than 5% of endometrial cancers. These patients are typically older and postmenopausal. Clear cell carcinomas look similar to ovarian clear cell cancers and are often composed of cells with abundant clear cytoplasm.
Carcinosarcoma is an uncommon, aggressive sarcoma that accounts for less than 5% of endometrial cancers. Carcinosarcoma is composed of a high-grade sarcoma with a high-grade carcinoma.
Instead of classifying endometrial cancers as type 1 or type 2, FIGO now classifies tumours as non-aggressive or aggressive histological types. Non-aggressive histological types include grades 1 and 2 endometrioid adenocarcinoma, while aggressive histological types include grade 3 endometrioid carcinoma, serous cell, clear cell, mixed carcinoma, carcinosarcoma, and the unusual types. Grade 3 endometrioid carcinoma is a heterogeneous disease, and in order to be able to classify grade 3 endometrioid carcinoma as aggressive or non-aggressive, we really need to look to molecular subtypes.
The 2023 FIGO guidelines recommend determination of the molecular subtypes, since each of these subgroups have a distinct prognosis and provide information on response to chemotherapy, radiotherapy, and targeted treatment. The 4 molecular subgroups are based off the Cancer Genome Atlas and include POL mutation, MMR deficiency, P53 mutation, and copy number low with no specific molecular profile, or NSMP. For patients with grade 3 endometrioid carcinoma, the prognosis depends on the molecular subtype. POL mutation patients typically have a good prognosis. MMR deficiency and no specific molecular profile have an intermediate prognosis, and P53 mutation subtypes are considered to have a poor prognosis. Molecular subtyping is performed on a biopsy specimen using immunohistochemical and molecular techniques and can be done on the endometrial biopsy rather than the hysterectomy specimen.
I remember sitting through so many gynae-onc MDTs and a lot of this just going over my head. All right, so this is a hell of a lot of information. Let's just do a quick recap and then work out how to put this all together. Endometrial cancer is the most common gynecological cancer in Australia and New Zealand. The lifetime risk of endometrial cancer is about 1 in 44, or 2.3%. The incidence of endometrial cancer is rising, mainly due to an increase in risk factors like obesity and age. Not only is the incidence rising, but so is the mortality rate.
The risk factors for endometrial cancer include age, obesity, early menarche, late menopause and nulliparity, PCOS or anovulation, unopposed estrogen use, estrogen-secreting tumour, diabetes, tamoxifen use, insufficient exercise, and a family history of Lynch syndrome, Cowden syndrome, or uterine cancer.
Protective factors include weight loss, including the use of bariatric surgery, hormonal contraceptive use, pregnancy, especially at an older age, breastfeeding for at least 3 months, diet and exercise, coffee drinking, smoking, and hysterectomy for patients with Lynch or Cowden syndrome.
Screening is not typically recommended but can be performed with endometrial papel and transvaginal ultrasound for patients at a high risk of endometrial cancer, like in those with Lynch or Cowden syndrome. This is typically commenced at age 30 to 35 or 10 years before the first Lynch-associated cancer in the family.
Endometrial cancers are classified based on histopathological subtype and molecular subgroup. Histopathological subtypes include endometrioid carcinoma, serous carcinoma, clear cell carcinoma, carcinosarcoma, mixed carcinoma, and undifferentiated or dedifferentiated carcinoma, and other.
Endometrioid carcinomas are further classified into grades based on the presence of solid tissue. Grade 1 is less than 5% solid component, Grade 2 is 6 to 50% solid component, and Grade 3 is greater than 50% solid component.
Non-aggressive tumours are considered to be grade 1 or 2 endometrioid tumours. Everything else is considered to be an aggressive tumour. For high-grade or grade 3 endometrioid cancers, we look to the molecular subtype to determine whether malignancy is to be considered aggressive or non-aggressive.
Molecular subtypes provide information on categorization and prognostic information. They include POL mutation, MMR deficiency, P53 mutation, and low copy number with no specific molecular profile. In general, POL mutations have an excellent prognosis, MMR deficiency and NSMP have an intermediate prognosis, and P53 have a poor prognosis.
So that sums up this week's episode on an introduction to endometrial cancer. We've covered incidence, risk factors, protective factors, screening, and classification. Now that you've got the baseline information, join us next week as we go through a case and work out exactly how to work up, stage, and manage endometrial cancer.
Thanks for listening to this week's episode of the Uterine Sound podcast. You can find our summary slides on Instagram later in the week. If you have any comments, feedback, or you want to fact check us, please reach out to our email at theuterinesound@gmail.com. You can also reach us on Instagram and Facebook at The Uterine Sound and our website www.theuterinesound.com. See you next time.